I'm Dr. Chadi. I'm a pediatrician and adolescent and addiction medicine specialist currently working at Boston Children's Hospital. So it's really a pleasure for me to be here and talk to you guys all about such an interesting topic. So topics for today, we're going to try in the time that we have together to really dig deeper in the topic of adolescent substance use trends and prevention and screening. I have no disclosures, and the outline for today is to start by discussing some of the trends that I think are important to know in primary care. We're going to discuss how to apply effective screening and prevention strategies with adolescents that are at risk or using substances. And then we're going to review some of the current guidelines and talk a little bit more about how we can actually treat these conditions in primary care. Let's get started. As an adolescent medicine doc, I always share some brain slides. Younger adolescents have some parts of their brain that are fully functioning, and one of the important ones is this reward and pleasure center of the brain. There really is a biological circumstance where adolescents have this predisposition to being inclined to try things that are rewarding without being able to mitigate the consequences of potential drug use or substance use long term. And so I wanted to show you a few trends. There's some really good news when it comes to substance use in general. People don't talk about this that much, but this generation of young people is using less alcohol and less drugs in general than the past generation, and significantly so. So this is an image from the Monitoring the Future survey, so a national survey of student drug use across the country that goes out every year. And what we can see is in the past 20 years, rates of binge drinking, so drinking 4 or 5 more drinks in one sitting, have really gone down 2 to 3-fold, which is really encouraging when you think about it. And this trend is pretty true for most substances, not all of them. There are 2 main exceptions, and I'll get to those in a second. There's some good work that we're doing in prevention, either as health providers or with the help of our public health advocates and institutions. And really, those drugs that are the most prevalent remain alcohol, marijuana, and nicotine. And so yes, we hear a lot about the overdose crisis and how this affects different age groups. Young people are affected, so even though young people are using drugs less in general, we're still seeing an uptick in overdose deaths in young people, meaning that there's still some work to do for us. And I mentioned that there are a few substances that are still being used a lot, and marijuana is one of them. We see the rates of smoking cigarettes has tumbled down 5 to 6-fold in the past generation. But in the meantime, young people are using marijuana at rates that are pretty similar. Why are people still using marijuana when all the other drugs are going down? And I think we're all aware of the context of increased legalization. And so I want to talk a little bit more about what happens in the brain when we use marijuana, because anandamide really should be the superstar here. So we all in this room, as I'm speaking, have a lot of anandamide flowing through our brains and nervous systems. And what does anandamide do? Well, it's our body's own cannabinoid molecule that really plays a bunch of important roles. And what does anandamide do? So this endocannabinoid system that I was mentioning is a system that is very important to control levels of different hormones in our bodies. And so really what this anandamide molecule does is it plays the role of a volume control nudge. So, we have all these other hormones. We have endorphins or dopamine or serotonin that help regulate things like feeling hungry or tired or feeling pain or feeling sad. And this endocannabinoid system plays a conductor role in trying to regulate these other hormones and their levels. So it's not helpful for a human being to be hungry and continue to feel hungry after having a good meal, right? So we need to bring down these hormones and these signals after we've recovered or we've acted upon those impulses. And so this is exactly what the endocannabinoid system helps us to do. But when THC comes from the outside world and kind of disturbs this balance, this is where we get some interesting effects. So if we look at the inside of the brain and where we have those receptors, both for THC and anandamide and our own, cannabinoid molecules, because they're the same receptors, we can see that there's a distribution in the frontal part of the brain, so this very important part of the brain to make executive decisions and plan things and think like a human being in a more evolved, quote-unquote, way than, other animals and living beings. And then there's this C-shaped part of the brain. Who can tell me here what this is? Brain anatomy here this morning. Looks like a seahorse. That's a clue, the hippocampus, right? So this is where we form our memories, and it's interesting to see how many pink dots are there, meaning lots of THC receptors. This deep pink or purple dot is the nucleus accumbens. This is the firing center of all the dopamine that comes from pleasurable sensations. And then a bunch of other receptors in the back of our brain and our cerebellum where we get our coordination controlled. So this makes sense when we start thinking about all the effects that marijuana can have on the brain and body. And so I wanted to just summarize briefly, what does marijuana do? And we talk a lot about marijuana. I think we hear a lot about the brain effects of marijuana. We're kind of maybe not as sure about the other effects of marijuana on the system. But really, marijuana has very broad effects on developing teens. And so in the brain, definitely some impacts at the level of memory, short-term memory and learning and judgment. And that makes sense when we're thinking back at the previous slide where all these THC receptors are located. We know that marijuana has significant impacts on mood and depression and can induce things like paranoia and lack of motivation. And we're getting more and more high-quality research showing that these effects are not reversible and do keep and stay with time. We know that depending on how we consume marijuana, marijuana can be mixed with other chemicals and produce a bunch of effects on the lungs and increased risks of bronchitis. In our adolescents, significant effects on sexual function, right? So regular marijuana use will decrease fertility in both males and females, can induce things like erectile dysfunction, decrease or create irregularities during the periods. In males can bring gynecomastia, can decrease sperm function. So a bunch of different things that some teens may or may not be aware. And then long-term, things like increased blood pressure and heart rate and risks of heart attack. So definitely marijuana is a substance that affects the body and brain quite broadly. And I think as primary care providers, we hear a lot about this. Who in this room has had difficult conversations about whether or not to recommend medical marijuana or think about medical marijuana with some of our patients? Is that something that's come up? Or parents asking, is that something my kids should be taking? What's the science? What do we know? So definitely we're getting bombarded by messaging from I would say big cannabis companies. There is a long list of conditions that are targeted by these products, and I must say that the evidence base is building, but there are only 2 conditions as of now that have a significant evidence base to show that marijuana can actually be something that we would recommend safely where the benefits would outweigh the risks. And those 2 conditions are in young people who are treated for cancer and have bad side effects from their chemo, marijuana can help increase appetite and decrease nausea. And in those kids with very severe epilepsy, then a CBD formulation, one of the chemicals in marijuana, can help decrease seizures. But in all these other conditions, we don't have solid science. It doesn't mean that it doesn't work. It just means that we know of many potential side effects of marijuana use, especially in young people with a developing brain. And we haven't been able to show that the cannabis formulations that we have available can actually produce meaningful change in a positive way. And so when it comes to speaking with teens about medical marijuana, I think, and I put a scale on this slide, it's really trying to balance the pros and cons. And so I'll open brackets here, and we do have limited research, but I think we're hearing more and more about CBD or cannabidiol. So the marijuana plant has about 100 different molecules in there. And those molecules, like THC, some of them have a psychoactive effect, so it can get you high. And some of them we think have different properties. CBD is one that is thought to have anti-inflammatory properties and possibly a positive effect on the immune system. And this has been shown in cells in the lab. But when it comes to studying that in children, we really have limited information. And I don't think that we're at a stage where we know yet what's the right balance of CBD and those other molecules in the cannabis plant that we should be putting in a pill or in an oil or in a formulation. So yes, these CBD products are out there, but once again, because there's a lot of unknown and they're not regulated as FDA medications, except for that one Epidiolex formulation that's recently been approved, if you order a CBD online or if you buy it at a medical marijuana dispensary, what you're going to get is probably some CBD, but also probably some other molecules mixed in together. And we really aren't that clear about the effects and possible side effects of what else is in those compounds or those formulations. So when it comes to recommending CBD, and I was asked that yesterday again on a consult, should a 10-year-old be prescribed CBD for behavioral problems, or is that an appropriate thing to try if we've tried everything else? What I think that the reflection that we need to have as providers is what are the effects of these other molecules that we don't understand and are probably present in these products, and we haven't studied long term. So definitely a lot of reflection. We have to listen to families and see where they're coming from, because I think there's a lot of hope and optimism, and rightfully so, that cannabis and medical marijuana could be a nice way to answer a lot of the problems that we have. But as of now, we have to be cautious in knowing that whenever there's a product with THC and some other of those marijuana molecules, we know that the developing brain can be highly affected by these things. There's a hand.
I have a question. In regards to like ADHD, like you just mentioned, it seems like a lot of kids with ADHD are being treated with stimulants. And I know that's not supposed to be a long-term solution, but isn't there some sort of balancing act between like giving a kid Adderall versus some CBD oil? Because Adderall is also not like really great for the developing brain.
Yes, great question. Thank you for bringing this up. And if you flip through my slide deck, I put some additional slides at the end specifically speaking about substance use and ADHD, because it's such an important topic. But because you mentioned it, I'll open those brackets now and talk a little bit more about it. So the bottom line is that kids and teens with untreated or not well-treated ADHD have a 2 to 3 time increase in the risk of having a substance use disorder, all substances combined. If the ADHD is well controlled, and by well controlled we mean like the symptoms are in check and kids are functioning in their environment, in their school activities, that increased risk of substance use falls back to baseline pretty much, right? So we can compare teens with and without ADHD, if they're well treated, as having a similar level of substance use. So I will challenge what you say about treating young people with stimulants, because as of now, psychostimulants are the most effective medication that we do have in our toolkit to help control some of those symptoms. That said, stimulants should not be used alone. We need to use behavioral interventions, we need to use strategies in schools and make sure kids are well supported with an IEP or a 504 plan, that there's some behavioral management with the family and a bunch of other things that come together. But stimulants in themselves are not harmful, and on the contrary can be helpful. And yes, there are side effects to any medication, and medications like Adderall or short-term stimulants have a significant potential for misuse. You can get high on those things, and they have a good street value. So as providers, when we prescribe those products in teens that have a predisposition to substance use or have had substance use issues, we have to be conscious about all those things. We have to be extra careful and trying to go for longer-term formulations that have less misuse potential, like prescribing for shorter time periods so that we don't give those kids a huge bottle of Adderall that they can go sell and exchange at school. Of course, all of those things. But to come back to your question about the balancing act, I wouldn't want to tell a parent that, oh, you can try CBD, because there is no evidence that CBD actually will help with the ADHD symptoms. There's some anecdotal evidence that maybe it can help. But we do have good evidence-based treatment that is FDA approved and well controlled that in the right conditions can really help decrease this risk for addiction, and I wouldn't separate both. So if a parent does want to try CBD for their kid with ADHD, there's no problem, I think, if they're well aware of the possible, negative consequences of trying that on top of the stimulants or other medications or other behavioral treatment that are out there. So I don't know if that answers that. I mentioned marijuana is one of those substances that is not going down in young people, and e-cigarettes and nicotine is that one substance that is skyrocketing in young people. And if you've read anything online about it or in the news or in the media, we know that e-cigarettes are this hot trend now. If we just look at trends, about a third of high school seniors, and this is from last year, I think it's outdated, in the area we're seeing indicators that e-cigarette use is actually quite above national average. A lot of kids will say, I'm vaping, just flavoring, or I don't think there's nicotine in what I'm using. What we do know is about 99% of all those e-cigarette products being sold out there do contain nicotine, and often high concentrations of it. So Juul is the #1 selling e-cigarette product in North America because of many of its properties that make it a very high-tech and appealing device. So if you've seen or held one of these, they look like a flash drive, more or less. They can get charged in a USB port in any computer, electronic device. They get charged with little cartridges that are about the size of your thumbnail. And each of these little cartridges that's flavored, one of those fun flavors like mango or cool mint or creme brulee, contains the same amount of nicotine as an entire pack of cigarettes, right? So This is a lot of nicotine and a tiny little bit of liquid. And you can go through one of these in 200 puffs. And if you really try, you can do that in 15 minutes if you think about your respiratory rate. So it's a very effective nicotine delivery device. And it's really the first time in history that we find an electronic device that can mirror the pattern of nicotine administration very closely to that of the pattern of traditional cigarettes. So traditional cigarettes are really like all-stars in terms of delivering nicotine to the brain. They do that very well. And as of recently, we weren't able to replicate that. And the Juul has, because of the way it dissolves the salts in the liquid and the device works, created a way to deliver nicotine very effectively to the brain. And so what is in this aerosol or this vapor, it is not only water vapor, and that's the really key point for young people to understand. So yes, there is nicotine in the Juul products and many of those other ones. There's a bunch of other fine particles and volatile compounds. So I think we hear a lot about how e-cigarettes are a cleaner, safer way of using nicotine. Fair enough. There are fewer chemicals. There's not tar and some of those really disgusting things that we find in cigarettes in those e-cigarettes. But there's a really long laundry list of other chemicals, including things like diacetyl and those heavy metals like nickel and tin and lead that are found in amounts that are significant. So if we think of a teen who would have not smoked a traditional cigarette and is now starting to vape, we're thinking about a whole new exposure to a bunch of chemicals that probably would not have been present at baseline had they not used any of those products. So I want to speak a little bit about nicotine in the brain because I think it's important for us to know as providers what we know actually about nicotine. So nicotine short term is a stimulant, so you get a bit of a rush and a head buzz if you use a traditional cigarette or an e-cigarette, and that's not news to you probably because we've known cigarettes for a long time. Nicotine is a very quick acting molecule. It gets to your brain in seconds, and this is in part what makes it so addictive. We talk about nicotine as one of the most addictive substances out there, close to cocaine and really just a little under heroin. And that's in part because it produces this surge in dopamine so quickly, and our body is eliminating it very quickly, meaning that we crave it very, very fast. Long term, and this is where it gets interesting, we're starting to know from animal research and early research in human beings that nicotine actually, although it's not been, significantly linked with cancer itself, right? Nicotine in cigarettes is not the part of cigarettes that we think causes cancer. Nicotine has impact on the brain and how the brain develops. And some of those effects that we're seeing is that a young person exposed to nicotine will have long-term reductions and impairments in their capacity to pay attention and do some work and learn academically, and is associated with things like mood disorders and impulse control. And nicotine is associated with the use of other substances. If we go back to this brain anatomy I was mentioning at the beginning, nicotine does sensitize the brain to the rewarding effects of other substances. And the big problem now is with this very rapid emergence of e-cigarettes, we haven't had a chance to develop effective treatment strategies for young people who present specifically with an addiction to nicotine through e-cigarettes. We really don't know what works best. What we do know is how to treat cigarettes or nicotine dependence through those other tobacco products. And I think something that we have to keep in mind is a lot of teens are vaping not only nicotine, but marijuana. We know that about a quarter of young people who have used an e-cigarette have used high-potency marijuana products in their e-cigarette. So that's a lot of kids. Depending on who you ask, about 10% of all adolescents will have tried vaping marijuana. And that, again, is perceived by adolescents as something that's very low risk. But when we think about it, a product that has 80 or 90% THC, like one of those oils, has a huge effect on how the brain develops and increases your risk of all sorts of mental health disorders and addiction to other substances. So we really have to be careful when we counsel teens about e-cigarettes, knowing that it's not a very big line to jump to go from vaping what we think is creme brulee to actually vaping a lot of nicotine and then trying with some of those marijuana products. And this is just a slide to show how common this is. And even in 8th graders, of those who vape nicotine, a bunch of those also vape marijuana. And those trends are rapidly increasing. In just the span of a year, we've seen like a doubling of young people vaping marijuana. So a few other trends that I'll mention briefly, because those are things that we also hear about. We hear sometimes about synthetic marijuana. And last year there was a big scare in Connecticut when a bunch of people overdosed on what we thought was synthetic cannabinoid, also known as K2 or spice. These are very short-acting synthetic molecules that bind to the same receptors in the brain and produce some of the similar highs or euphoric effects of marijuana, but have very dramatic side effects. Because they're so short-acting, young people tend to use them a lot in a short span of time. They're not detected by traditional drug tests because they don't contain the THC that we usually look for. And as I mentioned, the effects are euphoria and relaxation and altered perceptions. However, there's a slur of other health risks that come with the confusion, anxiety, paranoia, hallucinations. Those are all things that we will sometimes see in high-dose marijuana products, but we're seeing them a lot more in these synthetic forms of marijuana. And long-term, these molecules can lead to things like kidney damage and seizures and cardiac ischemia. So they definitely have a different risk profile. But I do have teens in my clinic, in my practice, that have told me that they have used those products. So we have to be aware that this is not marijuana. This is a very high form, an alternative form of a cannabinoid. A significant proportion of teens, and this is becoming more and more of an issue with the recent approval of some psychedelics for the treatment of things like depression, right? So we're hearing about ketamine, we're hearing about psilocybin as some potentially promising ways of targeting these refractory mental health disorders. So we don't have indications that this is something helpful to do in young people, but I commonly have young people that tell me, oh, I've tried acid or I've tried LSD and this has changed my life, or it's helped my anxiety, or it's helped my depression. So I think it's good to keep in mind what these things can do. So the risk profiles of these molecules really are linked to those hallucinogenic and psychedelic effects. So I think the one known consequence of young people using these things is getting what we would call hallucinogen persisting perception disorder. So a thought disorder, a perception disorder that persists, and that can be linked to things like psychosis and other mental health conditions. So in a young person that's vulnerable to mental health, using psychedelics, sometimes even once, can be a very deep and traumatic experience. Some will describe it as a very positive experience, but often these things will be used at very high doses or ordered online or gotten in different ways. So it's really hard to know what's in there. And the effects that can come with it are not so well understood and definitely can lead to things like psychosis. So we want to be conscious about that. All right. So I've covered some trends, and I do want to get into something a little bit more hands-on on what we can do as primary care providers to effectively screen and prevent all these use patterns from actually happening. And so I pulled this up because I thought it's relevant for us in primary care. So the U.S. Preventive Services Task Force recommendations in its latest edition, 2018, does clearly recommend screening for alcohol use and substance use in adults over 18, but still for adolescents in between the ages of 12 to 17, doesn't strongly recommend systematic screening, which is a position that I think is interesting, given that some large professional associations, including the one that I'm part of, the American Academy of Pediatrics, has been a very strong promoter of screening in primary care within annual health visits and even in emergency room visits. And so I think we can consider both of those, and I thought I would show the recommendations from the AAP, so the American Academy of Pediatrics, that really says that primary care providers and pediatricians should become very familiar with screening and become more familiar with these guidelines and what we should be doing in primary care. And so who here is familiar with SBIRT? Kind of fun buzzword that we're hearing more and more. So in short, SBIRT is this acronym that stands for the few minutes of something that we can do in our practice that can really pick up substance use problems, act on it, and then refer to appropriate resources. So we start by screening, we do a bit of a brief intervention, and then we refer to treatment when needed. And why we're hearing more and more about it here in Massachusetts, I think this is something that we can pride ourselves in. We are the only state currently that has a statewide policy requiring all middle and high schools to do SBIRT, not just in healthcare, but in schools. This is fairly recent and shows really an effort from our public health department and I think our health advocates to bring more screening, not just in healthcare, but also in schools. And so if you want to use a validated screening tool, and I'm sure many of you are familiar with some of these, and based on the response we'll get from those screening tools, we'll know what to do next. Either provide positive reinforcement, give a bit of advice, or do what we would call a brief intervention. But I think before we address any substance use or delicate issue with a teenager, and this is something that you probably are aware of, privacy and confidentiality is so important. And when I think about busy primary care visits, because I do work in primary and urgent care, I would say that spending 15 or 20 seconds on explaining what confidentiality means for a teen is not a waste of time, because you're probably going to increase the yield of the next question that you're going to ask. And what that looks like can just be, so what you're going to tell me is private or confidential. And what that means is if you tell me that you're using a substance, I will not tell your parent the details of your use or how many times you've used it, unless there's a danger to your health and safety or someone under the age of 18 is at risk. I would say that to all of my teens, and I will repeat that, and if they have questions, I'll try to answer. And what I've found, and what my colleagues have found, is that really increases your yield and your chance of their people feeling comfortable actually telling you anything about their substance use. So we want to encourage our adolescents to be honest and truthful, and we want to create a safe space for them to be able to share and make sure that they understand why and how we would breach confidentiality. So who here is familiar with the S2BI screening tool? I think this is probably the simplest screening tool that we have available that is evidence-based. And if there's one thing that you'd remember for today, it's this question. In the past year, how many times have you used? And then you would ask first about tobacco, nicotine, and e-cigarettes. Pause, listen for the answer. The teen tells you weekly, monthly, or once or twice. You get a direct correlation with the risk of having a substance use disorder. And this may sound surprising. You think, what? A young person using an e-cigarette weekly has a risk for a severe nicotine use disorder? How does that even make sense? Well, believe it or not, large samples of teens have correlated this data. So even if a teen tells you that they're juuling or they're using their e-cig only a few times a week, there's a high chance that they have a severe addiction to the substance. And you would repeat that question for alcohol and marijuana. And if you get a no for all three of those, you can be pretty reassured that your teen, if they're being truthful, and usually if you've done your job in explaining confidentiality, they should be, you have a very low chance of them having a problem with substances. And you can usually stop there and move on to another topic of your exam or your session. Right? If you do get a positive, you might want to ask about other substances like illicit drugs or prescription medicines or things like that. But this is a really simple tool that I would encourage all of us to use. The one that you might be a little bit more familiar about is the CRAFT. It has a very similar structure. So the initial questions ask about alcohol and marijuana and other drugs and nicotine. I put this one purposefully. This is the latest edition of the CRAFT. The CRAFT is being revised, and if you type craft.com, you can download all of these tools. This is the 2.1N that includes the nicotine question that also has the e-cigs in there. So if you're going to use a CRAFT, I would suggest using this one. And the neat thing about the CRAFT is it does all the work for you. Because why is it called CRAFT? Because of those 6 follow-up questions. C for have you ridden in a car, driven by someone who is high, and then R for relax, and A for alone, and F for forget. So those screening questions that are also good counseling and brief intervention questions. So if you get a positive around these points, you might want to follow up on with some brief advice about those things. And depending on your answers to those 6 follow-up questions, you once again get a direct correlation with your risk of having a substance use disorder as per DSM-5 criteria, right? So if you get 3 or more positives, you basically have an 80% chance or more of this young person sitting in front of you having a severe substance use disorder, which I would say would indicate future steps and follow-up. So, when we're screening, yes, we're using those tools, and, as you can see, it can be as short as a few seconds and asking that one question 3 times. But we also want to be looking for warning signs. So substance use can present pretty non-specifically with all these things that I've listed here, right? So falling grades or loss of interest or, risk factors like adverse childhood experiences or family history that might be part of triggering some of this substance use. So we want to be thinking about the big picture and all of those things when we're screening, right? Keeping our good clinical judgment. And so I want to move on to kind of the next part of SBIRT or screening. So this is kind of specifically using that one question that I mentioned earlier. So I think this is a nice kind of picture if you want to keep it all together. So if you do get a positive answer and you want to just provide a little bit of feedback and motivational interview, what do you do? Well, there's several different approaches out there. Who here is familiar with the 5 A's? That's something that we used to use a lot with tobacco cessation. I think it's a nice way to, in a few minutes, You ask about use. We've done that with the screening questions. As providers, it's always good practice to advise strongly not to use. Young people, if they want to do this, the healthiest and smartest thing for them and their brain to develop fully, they shouldn't be using any of those substances. But of course, we know that a lot of teens do. So we want to give them a strong message, being mindful that they might have used or might be using. And a good next step might be to look at their readiness to change or quit. And you can use a 1 to 10 scale for things like, how likely are you to reduce or quit your marijuana use or using e-cigarettes? And then you want to provide them with some assistance. I want to see you in a few weeks, or how about we speak with a counselor or someone we have in your practice, or why don't you want to go see your school counselor and try to set some goals, or I can help you with this, right? And then arrange, follow up with an appropriate professional. So this is one way of doing it. And as you can see, it really doesn't take all that long, and we've really proven that primary care doctors taking those few minutes to do that once a year in the annual visit or in the context of urgent care visits can really make a difference in reducing or delaying even the onset of substance use. And so a few key points if we're doing brief intervention: being patient-centered. No patient, and I was reminded of that last week, likes to be talked to as a problem. We had a patient in our clinic who didn't want to come back because one of the providers had said, your tobacco problem, and that's the only thing that the teen heard. And when she came to, she's like, I don't want to come back here because everyone says I have a problem. I don't have a problem. I'm not a problem. I'm a teen. I go to school. I dance, and I have all these fun things that I want to talk about. And that's a really good reminder that nobody wants to be talked negatively, and especially not teens. So we want to keep that in mind. And again, if you're going to spend a few minutes or a few seconds to kind of create this alliance, you might want to ask about the really cool pair of shoes, or like their skateboard on their arm, and how that brings them joy in their life. If you're going to ask about hard things like quitting drugs after that, advise them to quit. Again, this is a strong message that really goes far. We want to provide a little bit of information. I've shared some information in my first slides about some of the things we know about using marijuana and other substances. Maybe something that resonates to you and you want to share. Maybe something that you can share with your teens. You want to be non-judgmental as much as you can. As far as we know, wagging the finger or telling teens you shouldn't do that because it's bad has not proven to be a very effective strategy. You can suggest what not to do, but you don't want to reprimand them or judge. And then again, as I was mentioning, using things like willingness scales. And so if you're engaging in a bit more of a discussion, I'm sure you've heard about motivational interviewing at some point in your training. And motivational interviewing is really this idea of a dialogue where we help a young person navigate the stages of change and help them become more inclined to make their own efforts to go towards healthy behaviors. And change is hard, and there's ambivalence that comes with it. But we won't be there at home with these teens after our visit. So we want them to come up with the keys and the tools to make the change that will be helpful for them. So I'll talk briefly about treatment. I just wanted to bring your awareness to what it means to be in treatment for substance use when you're a teenager. And there's a whole continuum of care. And sometimes, we see our teens in our practice and we don't know that they might have been through a bunch of those other steps that are out there. And there are a lot of substance use treatment resources for teens in Massachusetts here. And, it starts with community support and prevention programs and school interventions. And primary care visits are key at screening and early intervention. But sometimes it's heavy and it's a lot. So we need to refer to specialized outpatient services, and there are some in the area here, and I'll get to that in a second. And some of your teens might require something more, like an intensive outpatient treatment program where they're in a group or in a program for a few hours, a few days a week, or even every day in a partial hospitalization program, and those programs do exist. And we have residential treatment programs and concurrent disorders programs, and sometimes they'll present to the emergency room because they'll do it and they'll overdo it, and we'll see these teens in primary care afterwards to counsel them and take care of them overall. So what are the things that might happen if we're thinking about therapy for a young person or counseling in the context of primary care or a specialized clinic? Well, the approaches that have been shown to be successful are motivational interviewing. CBT, or cognitive behavioral therapy, is really one of those things that has a strong evidence base for those conditions where we don't have medications to help, for example. Dialectic behavioral therapy programs and contingency management programs where you would talk about incentives and rewards are all things that can be helpful in treating teens with substance use problems. So I mentioned outpatient substance use programs. So we have a lot of teens from this area here who come to us. I work in the Adolescent Substance Use and Addiction program at Boston Children's. So we take referrals for 12 to 24-year-olds. We have a multidisciplinary approach with pediatricians, psychiatrists, and social workers. So if you have teens with problems that you think might require a little more, that's a good step. Mass General and Boston Medical Centers have similar programs. The wait lists for those programs are usually pretty short, so these teens get seen within a week or two. So that's a good thing to know. I'll speak about this briefly, and this is kind of a growing field. We now have a few medications that really can be helpful in treating kids with substance use problems. With nicotine, we know that we can use nicotine replacement therapy for young people 12 and up. So the patches and the gums and the lozenges can be used with teens that have cigarette use or even e-cigarette use. We can use medications like bupropion or Wellbutrin or varenicline for those 16 and up, and that can increase their chances of quitting. Who here has used naltrexone for teens with alcohol problems? Good. It's good to see the hand. So this is something that we're using more and more. It's a very safe medication in the majority of situations. It's something that can be used as a pill once a day or as a monthly injection, can really reduce cravings, and also will usually decrease the amount of heavy drinking. Because when you drink on naltrexone, you don't get an anti-abuse or an adverse effect, but you feel full quicker and you don't tend to want to drink as much or get as intoxicated. So it can be a very helpful tool. Unfortunately for marijuana, we're still looking for something that can help. There's some, anecdotal evidence that NAC and acetylcysteine can be helpful in reducing some of the cravings. I'm not convinced, but this is a fairly benign, again, product that can be purchased as a kind of a supplement that can be tried. And then for opioids, if you have that, issue come up in your practice, we have highly effective medications, buprenorphine, naltrexone, and methadone. And who here is waivered to prescribe buprenorphine? This is great. And if you're not, there are a lot of trainings. So I mentioned some of these, and I think I'll leave those for you to review in my slides. I'm just talking a little bit more about those kind of more intensive programs when outpatient treatment is not enough, and I've mentioned those, but they're out there. And usually the best way of knowing what the resources are around you are to either call SAMHSA to know what their treatment locator is, or find their website, or call the insurance companies directly. So I'll kind of close with this, and I think this is maybe food for thought. So what can we do as primary care providers to support teens with substance use problems? So, a lot of the time these are teens that have a lot of risks, and those teens that fly under our radar might be teens that we've seen since they were young kids and we're not suspecting have substance use problems, or they're those teens that just don't show up to our appointments, and we have this connection and this ability to catch them at a point where things are really shifting. And so I think one thing that we don't use enough is communication. So I work both in primary care and as a consultant specialist. I would love to speak with primary care doctors as much as possible to discuss the management of difficult cases. Those resources are there. And although we have all these treatment resources, it's a very Swiss cheese type of system. It's not rare that a teen's going to go to a 3-week inpatient residential treatment, get the highest level of care, and then be sent back to their primary care doctor with no follow-up plan, no therapy, no kind of transition. They're just sent back to school and expected to be all healed, that those cravings for whatever they were using are going to disappear. I think it's even more important, and not to take for granted that if young people are getting more treatment or more help, that they're all set. It really isn't that, unfortunately, not yet. So we have to think about that. And being that steady figure and caring for those teens regardless of what happens, and reaching out frequently, and being able to balance, keeping that therapeutic alliance and making those tough decisions when it's time is really important. Okay, so I've shared a few resources in my slides. I'll just quickly go through. If you want a nice summary text, this is something that I wrote with some colleagues that I think touches a lot of the important points, and if you have trainees that you want to share with. If you want to read a little bit more on motivational interviewing, this is something that I always have to refresh on. What are some of the tools and the skills that you can use? This is a good resource. If you're in your office with teens and parents and they're asking questions and you're not sure where to point them to, I think that the NIDA, the National Institutes for Drug Abuse, is a really good resource. They have a teen page, teacher page, parent page, and then a health provider page that has all these drug facts on these new and emerging drugs. If you're thinking specifically about e-cigarettes, there's a lot of really good handouts out there, and two of the sites that I like are the Surgeon General site that has resources for professionals and parents. And the AAP with its Richmond Center has good handouts that you can even print and put in your clinic space about the Juul or about e-cigarettes and some of the risks. then again, there's a lot of really good local resources in Massachusetts. One really fun thing is that the quit lines that used to really be tailored for adults mostly now take calls for young people. So adolescents that call and say, I'm addicted to my Juul or my e-cigarette will be counseled appropriately now by the quit lines. It used to be last year that if you were a teen and you called with an e-cig problem, they would tell you, oh, that's great, you're using an e-cig, that's awesome. It's just interesting. And there's a lot of good advocates and websites that I've listed here with some good printouts again. This is a site that I particularly liked. A Canadian colleague and friend of mine developed this to look at interactions between all sorts of prescription medications and all the street drugs and substances. If you're prescribing something to a teen, this is a great tool that teens can use and they can see for themselves, and it uses nice pictograms, so it's something that adolescents usually like a lot. The AAP has some good substance use resources, and especially stuff for parents, how to talk to their kids about marijuana. This is something that I've written recently about medical marijuana for parents, because I get so many questions about this, so it could be helpful as well. And this is a new service through a partnership for drug-free kids and then Graykin at BMC. It's an around-the-clock helpline and texting service for parents staffed by social workers that might have issues after hours around substance use. So this is a good resource to know also. And parents sometimes will need help, so there are really good coping groups where parents can go in a judgment-free space and talk about substance use problems. That's one of them, and there are groups in the area. And this is a quick acknowledgement to my team. We accept referrals, as I mentioned. We have a satellite site in Waltham that might be easier to access in the area here with free parking. And so we have a longer waiting list now, but usually we see teens within a week or two. And patients can self-refer, families can self-refer. You can place the referral either by calling or sending an email. And this is what I was mentioning. If you're in your office and you're stuck and you're wondering, how can I help this teen with all these problems? This is a great number to call. They will be able to tell you what's around in terms of higher acuity services, or where should I go next when it comes to referring or making sure my teen is safe. All right, so I'll conclude with a few take-home points. Yes, substance use is decreasing overall, so that's good news, but there's some increase in rates of nicotine use, and marijuana use is still there. And we want to be patient-centered in our approaches, talk about confidentiality, and try to reduce substance use and delay it as much as we can. Treatment for substance use is complex, does evolve around, along a continuum, and as PCPs, we can really play a key role in navigating those different stages of treatment, preventing, and making sure we communicate well with our families. There's a bunch of other slides at the end of my deck talking a little bit more specifically about drug testing, if that's something that you're considering for your practice. So I'll stop there.